And so it is such a sort of bread and butter, condition that we see in all settings within pediatrics. With regards to asthma, I've not only gained so much experience in managing it because we simply deal with it on an almost daily basis, but I've really had to change my view of how us managing pediatric asthma goes so much beyond just managing the medical aspects of it, because there's such a huge it's really a reflection of the kind of community that the child is growing up in. But it absolutely can impact both the severity of asthma that a child may have, their awareness and literacy around it, and ultimately how one's health outcome may be. So that's it's definitely a condition that I am very passionate about in terms of managing, but also closely understanding.
You are listening to the Pinnacle Podcast, where we empower women in medicine through education, community, and actionable strategies for both the practice and the business of medicine.
Medicine is a lifelong career, and continuing education is crucial for professional development. Pinnacle is the first and only multi-specialty organization dedicated to addressing the challenges that all women in healthcare face.
Welcome to Pinnacle, the elite professional community providing education for women in medicine. At Pinnacle, we challenge you to pave your own path by helping you develop the skills needed to not only stay in medicine, but to excel.
Welcome to the Pinnacle Prescription Podcast. I'm your host, Dr. Pamela Mehta, and today I am joined by Dr. Arunima Bera for Asthma and Allergies Pediatric Critical Care. Arunima Bera is a board-certified American Board of Pediatrics and Pediatric Critical Care. She is currently an inductee of the Teaching Excellence Academy at UC Riverside School of Medicine, and she was recently awarded the Young Investigator Research Award in 2019 by the American College of Chest Physicians. So we are super excited to have you here today, Dr. Bera. So first, I'd love for you to just tell us a little bit about yourself and kind of how you got to where you are today.
Thank you so much for having me, first of all, and thank you so much for being, one of the three founders of the whole Pinnacle movement and organization. I can safely say on behalf of a lot of women that it's just been such an incredible experience to witness this. And I was at the Pinnacle conference recently, just a few months ago, and it was an absolutely amazing experience. So a little bit about me. I am a, pediatric ICU physician, as you mentioned. A lot of the lens that I come in with in medicine is also of an international medical graduate. So I was born in India, but I grew up partly in India and then the Middle East in Qatar. And actually, that's where I started my pre-medical education and about half of my med school. So I was at Cornell, but the Qatar program, which was a very unique medical education experience because it also allowed us to do a lot of rotations and gain a lot of experience in the New York campus. And so I feel like a lot of my experiences and perspective have been shaped from an international background, but very much also having assimilated into, the medical system in the United States. And I've just been able to gain so much, of course, knowledge and experience through my training, but really been able to mold my perspective as an attending working largely in a medically underserved community, which is what I've largely been doing out of once I graduated. So I'm still relatively early in my career, but I have really learned so much, just by working in communities and areas that don't always have all the resources that is easy to take for granted when you're in a big city academic program. And even though I am currently in academics, it's a really interesting balance of being an academic physician, but in a medically underserved area. So yeah, that's a little bit about me.
Wow, that's great. So I do actually want to touch upon this because you mentioned it. Tell me what barriers you may have faced coming from as a foreign medical grad to the US. I'm assuming you did your training here. Is that correct?
Uh,
Before you
so it was about, I would say, 60-40. So most of the training was actually back home, or when I grew up in Qatar. But then a lot of my clinical rotations, the sub-Is that we do in the latter portion of our third and fourth year, I actually got to do at New York Presbyterian in New York.
Oh, that's awesome. So
Yeah.
where did you do your residency?
I did my residency in Buffalo. So I went upstate after graduating from medical school, and I was in a standalone pediatric hospital at University of Buffalo for 3 years. Um, After which, and that was an amazing, training experience. Got to see a lot and gain a lot of experience. And then I knew during my residency training that I wanted to further specialize in critical care, in pediatric critical care, and that's when I moved to California and trained at UCLA.
Okay, wow, that those are great credentials, and I think I want to highlight for our listeners, because we do have some younger women that may be listening to this, that you are a foreign medical grad, and sometimes people get a little worried about that and being able to find a residency spot and a fellowship spot in the U.S. But it sounds like you were able to do that. Were there any barriers when you were applying for residency and fellowship? And maybe you can share just briefly on that.
Yeah, absolutely. And I'm so glad you're asking this question, because really my whole platform, both online and in person, is to try and raise more awareness on challenges that IMG physicians face right from, school onwards. I would say one of the largest barriers, even though, I graduated from an Ivy League school, from Cornell, but it was this hybrid of an international program with the US, was simply recognition of my credentials and my background. So while, at least back when I was applying, one of my colleagues who's a US grad would apply to, say, 15, 20 programs in residency, right? I had to apply to at least 90 to 100 programs, and about 30-40% of those programs probably never even opened my application.
Wow.
So I would say that is probably one of the biggest barriers, in that a lot of training programs, both residency and fellowship, because you're coming in with this additional layer of having an international background of education, where sometimes the school may not be as well known or recognized in the States, but then also having to have a visa, right, to study and work in the States. And a lot of programs are willing to, accept applicants who may need a work visa, but a lot of programs are not. And they may not tell you that right away, because I mean that would be outright discrimination, but there are ways for, unfortunately, you to not be even considered by them. So that is unfortunately a possible, barrier to entry. Um, of course, despite that, up to 25% of our physician workforce in the US have had some sort of an international background. So I would say, despite those barriers and challenges, both on a personal and systemic level, there are so many doctors of all different diverse backgrounds from all over the world who are very much part of the fabric of our healthcare system here in the US, where they're able to share their unique perspectives, their, acumen, their research insights. I mean, I think that's really why the US, compared to so many other countries, we are such a hub, right, of innovation and research and cutting edge technology, and things like that. And I do. Yeah.
Absolutely. And I think, I think you explained that so beautifully, is that part of what makes us unique in the US and makes us so innovative is that we are a fabric of individuals that come from all over the world.
Mhm.
And every study shows that not just in the clinic setting, but also in the research setting,
Mhm.
that diversity is so incredibly important. So kudos to you for, achieving so much in your career already. And I know you said you're
Yeah.
pretty young and out of training, but that is great. And I really want our listeners to gain from that, that inspiration from that it is possible, even though you had to put in so many applications,
Right.
and were, not passed over or not even looked at. It is still obviously possible. So let's
Absolutely.
fast forward to your, you graduate from UCLA as a fellow in ICU. How did you, I guess, get interested, or was there some special training that was related to the allergy asthma realm?
Yeah, so, dealing with asthma, especially pediatric asthma, it is the most common childhood condition. And it's one of the most common reasons for a child to visit the ER. And allergies are very intricately connected with asthma because it can be, very closely associated with it, right? So a child with asthma may also have either environmental allergies, food allergies, or simply other forms of allergies that may trigger them. And so it is such a sort of bread and butter, condition that we see in all settings within pediatrics. So I would say right from the clinic to the emergency room to the inpatient floor in ICU, which is where I largely work in. And so, with regards to asthma, I've not only gained so much experience in managing it because we simply deal with it on an almost daily basis, but I've really had to change my view of how us managing pediatric asthma goes so much beyond just managing the medical aspects of it because there's such a huge it's really a reflection of the kind of community that the child is growing up in, where there are a lot of essentially, now the big buzzword is social determinants of health, but it absolutely can impact both the severity of asthma that a child may have, their, awareness and literacy around it, and ultimately how, one's health outcome may be. So that's yeah, it's definitely a condition that I am very passionate about in terms of managing, but also closely understanding.
Okay, that's great. I know that there is a lot of misinformation
Mhm.
about allergies and asthma. Maybe you can clear up some of what you read on maybe social media or on some throwaway, news links,
Mhm.
and things that you would like to fight off with the right information.
Yeah, absolutely. I think first and foremost, and I'll speak on asthma first, just because again, it's just so unfortunately still so prevalent, including the county, the community and the county that I work in. I think, it's really unfortunate that there's still such a stigma against asthma as a whole, but also when a parent hears that their child may have the diagnosis, they still feel very fearful that their child may be labeled as an asthmatic. If you see in the media and in movies, I mean, it's so lame, but you still see, that child who's bullied who then has to like pull out his or her inhaler. And, they get so nervous because they're
And they
having a
usually
panic
have
attack. Yeah.
glasses, and they're skinny and they're a little bit
Right.
nerdy, and it kind of is like this trifecta of the things that maybe kids don't want to be, and
Yeah.
it doesn't look cool. So
Right.
maybe
Right.
you can explain to us about what kind of what it looks like to have asthma and live with asthma as a child.
Right, absolutely. It can really sometimes make the child feel like they're being isolated, right? Because it's something that makes them different. But the way that I try to explain to the child at a level that's appropriate to their age, but more importantly to the family is like any other chronic medical condition, this is just a part of your child's life, that it is not to define how they will, live their life currently as a child, how they are about to grow and develop. Because unfortunately, with asthma, it's a breathing condition, right? And it's largely a mix of an inflammatory condition with some autoimmune aspect to it. And it is something that, if not managed well, can potentially impact how they walk, how they run, how they move, how they're able to function in life. But the way that I explain to them is with the right tools, with the right education, and also just the right outlook in general, it is absolutely manageable. And this is actually something that when I was in residency, my late mentor, Dr. Michael Bai, may he rest in peace, he used to have, when we would round on our patients, inpatient, he would have a ready reference of Olympians and athletes who had asthma when they were children. And he would just mention them as this visual of they're not just living a regular life, they're able to live an extraordinary life, and you
Yes,
can
that's amazing.
absolutely do all of those things despite having this condition. So I've found that to be such an effective tool in really driving home that point. Along with that, I get right into it. I love teaching. I love, trying to make education as accessible and comprehensible to my patients. So I'll get up on the drawing board, do my very basic, drawing of lungs and airways and, how asthma may affect their airways, but then the medications that we give them, how that helps open up their airways, and really try to make the child feel empowered, when they go to school. This is your inhaler, this is your spacer, this is how you use it. Don't be afraid to speak up when you're having problems with, breathing, or when you're feeling nervous, or before you're about to, run on the field. Because exercise induced bronchospasm within asthma is a very common problem as well.
Do you
So
think nowadays more people are being diagnosed with asthma? Has there been some environmental factors that have changed things? And then I'd like you to pivot in speaking about allergies as well as it relates to environmental factors as well.
yeah, absolutely. And that's such a great question. So, within the US, if we were to just focus here for a second, I mean, even within the same state or region, there are a lot of regional variations in prevalence of asthma, and it's very closely tied to the environment. So, for example, in the county that I am in, the levels of air pollution are amongst the highest, and that definitely has resulted in an increase in the diagnosis and prevalence of asthma in children. It's really interesting. Just I think yesterday or the day before, Congresswoman AOC, so she was in a hearing about environmental chemicals, and she was talking about how, she represents Bronx and Queens in New York, which have the highest rates of childhood asthma and also ER visits, and how she was talking about these large corporations dumping chemicals like PFAS, and God knows what other chemicals. And obviously they don't have any responsibility on how they are contributing to really worsening healthcare outcomes. And I think collectively we are seeing that these chemicals may contribute to worsening of so many other conditions, right? Not just asthma, allergies, but also some forms of cancer that are largely coming out in research and also in the media. So that's what I have both, read about, but also what we are seeing in the clinical setting. And sort of concurrently, we're also seeing that, allergies have a very close role to play in informing us on the risk of asthma that a child may have. So, when in pediatrics, we talk about the atopic triad, which is, asthma is one of them, allergies is one of them, and then eczema, basically. And these are all sort of siblings in the sense that if you have a strong family history of either of them, and if you have a child who's coming in with a first time episode of wheezing, where you're not really sure if they may or may not have asthma, having these other points of information in terms of if they have a strong family history of food or environmental allergies, eczema, or asthma, that really informs us on what the risk may be in that individual child. And so, one of the, misinformation um, points around allergies, which I think is slowly, getting addressed pretty effectively, is just in terms of early introduction of foods to our infants and toddlers. So I think even about a decade ago, there used to be this real fear of introducing things like peanuts, tree nuts, eggs to our kids, because understandably, because there is a pretty significant prevalence of allergies of these common food groups in children. But I think we've really gotten around the fact that by introducing them early on, you may actually sensitize the child by exposing their immune system, right, to these to these food groups, and then sort of figuring out whether or not they may have an allergic reaction or not. And of course, this is all within the context of, if you as the pediatrician or the allergist know that there is a strong family history of either allergies or even anaphylaxis, you need to be very cautious about then educating the family about introduction, right? So instead of, say, introducing all of them at once, you want to be very, very careful. You want to definitely educate the family on what signs of allergies there may be, including signs of anaphylaxis. And of course, if they were to exhibit any of those, to, bring that to the attention of their physician right away or their clinician. But all of it is largely a risk benefit analysis or a discussion that we always have in whichever setting with the family and their child.
That was a great explanation. Thank you. And like I described to you earlier, we have a large audience of listeners. For our primary care family medicine colleagues, what would be your advice to them as to how to guide a brand new family dealing with either asthma or allergies, and especially when they're younger and that
Right.
there can be some things done about it?
Right.
How would you advise them, since you're super specialized, obviously?
Right, right. Despite me working in an inpatient or hospital setting, I actually try and do a very comprehensive sort of intake when a child comes in with asthma or with an acute asthma flare up. So, this is what I would advise for anyone entering primary care or already in it. Really try to take a very detailed history. And I just don't mean in terms of their symptoms. So, we have our algorithm, right? Like, how many times do they have nighttime awakenings? How many times are they coughing or wheezing in a week? Or do they need their inhaler? That, of course, is very important. But the other big piece of it is their environment. So, when was the last time their house had an inspection for mold or for other types of environmental issues? Are they near an oil refinery or near, large areas of wastewater dumping sites? Now, some families may know that, some families may not have an awareness of that, but it's important to ask those questions, right? um, and also, just in terms of what is their access to healthcare like, how easy it is for them to get to either the clinic or an ER, for them to be able to understand really what do these medications do and how much can they help in alleviating their child's symptoms. I think once you have a broader understanding of all of these factors that very much may impact their child's condition, you're then better informed to advise them accordingly. Right now, of course, it's not practical for every single family to just up and leave where they may be living, unfortunately, because again, the environmental pollutants and those factors are unfortunately just getting worse in some communities. But that's just an extra level of awareness that it's really important to have as a physician. So that would really, because that's what I've had to learn by working in these communities, by sort of stepping outside of my city bubble that I was before. And so it's just really important to address that.
Okay, great. No, I think that's great. That's a great pearl to give to our family medicine colleagues. Let's switch now gears to the type of practice you're in. You mentioned that you're at UC Riverside. You were awarded this research award. Can you tell us a little bit more about that?
Yeah, absolutely. So this research award was actually towards the latter part of my fellowship training. And it was when I presented my research. At the time, I was focused on learning and doing research on pediatric ARDS and sepsis. So ARDS meaning acute respiratory distress syndrome. It is something that we see, not uncommonly in our pediatric patients, pretty sick in the ICU. And so my project at the time was looking at certain biomarkers that we were able to measure in serum of patients with pediatric ARDS and correlating them with, their risk of serious organ injury and death. So I was able to do an oral presentation at CHEST conference, which is, one of the leading national conferences in pulmonology and critical care. And that was an incredible experience, right from learning how to make a really effective presentation, fit for a national level conference, and then being, recognized for the work that our team had done. Yeah.
That's great. So tell us what a day in the life looks like for you, because you are an academic. You
Hmm.
see patients inpatiently. I'm assuming you do some research still, but
Yes.
maybe if you do or don't, yes, please tell us like what a typical day, typical week looks like for you in your practice setting.
Yeah, absolutely. So currently, I work as a pediatric ICU hospitalist. So I do actually a bit of both, where I see admitted patients on the inpatient side, actually also see healthy newborns and co-manage a neonatal ICU. So we also see very, little premature and term newborns with our neonatology department. A day to day, so I actually largely do 24-hour shifts. That's been my format for a little over a year now, and that's been interesting in terms of managing my energy throughout the shift and then lack of sleep that I have when I'm working and trying to catch up with it afterwards. It's been an interesting work-life balance that I'm, working towards. So I have on most days our UCR medical students who come and rotate with us in the pediatrics department. And I love that. I love teaching our students. We also have family medicine residents who come in to get their pediatric experience. We attend C-sections of our, newborns and our premature newborns. We do consults in the ER, and that's really where I actually see a lot of critically ill patients, who come in where we help stabilize them. And then sometimes we may have to transfer them to a higher level center. And as well as do consult with patients from other surgical services or wherever else in the hospital. So I'm really like the one-stop shop of an inpatient pediatrician for the whole hospital. And it gets busy, it gets very dynamic. No day is the same, but that's what I love about, being an inpatient physician, that it's, there's always something new. um, but it's definitely one of those things, to just be very real, where you really have to prioritize your own wellness. And I mean the very fundamental things, being your rest, your sleep, just your mental well-being, especially when you're done with your shift, because some shifts can be really rough, especially during the winter time. But yeah.
So, what do you do to take care of yourself? I know that you like to sing,
Hmm.
and also you enjoy spoken word poetry. So, tell me what kinds of things do you do to feed your soul when you're not working, which will also obviously help you when you are working to take care of yourself.
Right,
What are
right.
some of those things?
That's a great question. First and foremost is sleep. And truly, I have learned this the hard way, but there is no substitute for good quality sleep. And I definitely accumulate some sleep debt on a shift, but as much as possible on my days off in between shifts, I will get my sleep. Sometimes that's up to 8 or 9 hours, but that is easily the biggest way in which I start to feel more grounded. I just feel like my energy is coming back. I try to get at least 15 to 20 minutes of sun, on my off days. So that's either by light movement. I love lifting weights. I feel like especially every woman should be lifting to, help with our bone density and our muscle mass and even our mental health. But yeah, just some form of movement really helps me. Actually, it's a big form of mindfulness for me. And honestly, one of the other big forms of self care for me has been talking about the things that I struggle with. So sometimes that's just to myself, in form of journaling. Yeah, music and singing, it's a huge form of, self-expression for myself, and also, just connecting with my friends, my community. But uh, it's also in just talking about these things with my friends who are in medicine and also with my students. I'm hopeful that, our generation of doctors onwards, that we show that it is completely okay to be open and vulnerable and really our authentic selves in talking about the things that are the not so easy parts of working in medicine. And I feel like I didn't quite have that when I was in training. There was a lot of sort of, you got to be resilient, you got to be tough and strong and be a wall and nothing's going to affect you. But I've really had to sort of break through that. And yeah, so I'm very open about that. And
No, that's great to hear. I think that's so important for people to really take in and absorb and practice. I think traditionally medicine, we're sort of just expected to, I hate to say this, but be stronger than most professions and people, and
right,
just sort of carry that weight and not express it or deal with it. So
right,
I think we are leaning more into that in this new generation, which I think is going to be so important and is only going to allow for physicians to have less burnout, which means in turn better patient care. So I think it
absolutely.
is going to have those long lasting effects, which is really nice. So I know you came to Pinnacle this year.
Hmm.
And so we always like to ask our faculty and our guests what would be their pinnacle pearl to share with other women?
Ooh, okay. I'm gonna try and make this as concise as possible, but feel free to paraphrase me in case it gets a bit lengthy. So
That's
really,
okay.
my main pearl would be that you always have your own unique perspective and, your own value to add to what is already a very vibrant community of physicians and clinicians. So never underestimate that. Your own unique experiences and background, it's always going to go a long way in actually connecting with your patients and with your community. So bringing that authentic self is always going to be a huge plus. My other pearl, if I may add, to kind of recap this great conversation we've had, is at some point, the education that we have within the four walls of our classroom or even within the hospital can only do so much. The real learning really exists in the outside world. So, keeping your eyes and ears open, really talking and listening to your patients, and keeping in mind that we all may have certain limitations of our own, but being willing to acknowledge that and to work on that is really going to go far. That's what I'm learning.
Oh,
So,
I love both of those so much, and especially your second one, because that is why Pinnacle exists.
mhm,
It's because we realized that there was a necessity for education
mhm,
outside of those four walls, and for there to be community and networking and shared experience of all the things that we encounter out in the real world
mhm,
that may be unique to women, but maybe all physicians or healthcare professionals.
right.
But that is the reason Pinnacle exists and why we're doing this podcast and why
Mhm,
we have you as a guest today, is so that we can learn from other experiences and go out there and seek our own path and kind of, as you said, learn from our surroundings and seeing and keeping an eye and ear open to what may not be written in a book somewhere
right,
or lectured to you when you were in school, right?
right.
So thank
Absolutely.
you so much. This has been an awesome conversation. I want our guests, sorry, our I want our listeners to be able to find you. So please tell us where they can find you online.
Yeah, absolutely. So currently, I have a blog on Instagram. It's called nimanotes.md. So just spelled NIMANOTES.md. That's really where I share a lot of lessons that I have learned. It's kind of like an open photo journal. I also share some of my music and covers that I do. So yeah, I think that's the easiest way to get me. To
Okay,
connect
that's
with me.
great. That's awesome. Thank you so much. We really appreciate it quite a bit today talking to you.
Thank you so much. Appreciate it as well.
Thank you for listening to the Pinnacle Podcast, where we strive to elevate the voices of women in medicine and inspire excellence across the healthcare landscape. Until next time, keep reaching for your pinnacle.